Hi everyone, my name is Mary O'Keefe. Thanks for joining me for this interview about the European Pain Federation's new position paper about opioids for chronic non-cancer pain. To speak about some of the important issues, I have here with me two of the position paper authors, Bart Morlian and Kevin Bowles. So Bart, Kevin, thanks so much for joining me and taking time out to do this interview. Would you both like to start off by just telling us a bit about who you are, what you do, and then we'll get into the questions. Maybe we'll start with you, Kevin.
Sure. Thanks very much for the part of this, Mary. My name is Kevin Bowles. I'm a clinical psychologist by training, and I'm currently a professor of clinical health psychology at Queen's University Belfast. I was one of the three co-chairs of the task force for these guidelines.
Okay, and Bart?
Yes, Mary. My name is Bart Morlian. I'm currently directing a multidisciplinary pain center at the University of Leuven, where I'm also appointed as a clinical professor. And I was involved also from the start in this project. Currently, I'm the immediate past president of the European Pain Federation.
Okay. So we'll start with you, Bart. So the first question, what are the paper's top 3 take-home messages about opioids for chronic non-cancer pain?
Thank you very much. So sorry, I'm getting lost here.
No, it's no problem.
We
go again?
You're doing just fine.
Yeah, we'll restart. Please put a question, and now I'll run through.
Okay. So Bart, what are the paper's top 3 take-home messages about opioids for chronic non-cancer pain?
Indeed, I see 3 important take-home messages. And the first one is that even before considering opioid treatment for chronic non-cancer pain, we suggest to optimize non-pharmacological approaches and the use of non-opioid medication. And thereby we do acknowledge the complexity of chronic pain and also putting chronic pain in a biopsychosocial framework. And a general principle is that opioids are never the first step and never the first choice in the management of chronic non-cancer pain. A second take-home message is that we acknowledge and give clear recommendations that opioids do not work in every type of chronic non-cancer pain. So we clearly give guidance in which cases you can consider opioids and other situations where you should not use opioids. And then thirdly, we stress really the need for individual care for the selection process, the assessment, reassessment, and this is key to prescribe opioids, especially on the long term. So individual care with attention to details is needed. We give also, and this is really new in our recommendations, we also address specific clinical cases and special situations and give also guidance how to taper and stop opioids.
Okay, great. Thanks, Bart. So Kevin, the next question. So the papers bring attention to the harms of opioids. What are the most serious harms and how common are they in this population?
It's a great question, Mary. Thanks for it. The thing that the task force emphasized and that I want to emphasize here is that opioids have significant potential for both benefit and harm. And much has been made in various venues about opioids' potential for harm. But if one looks at the literature, opioids have significant probability of benefit when used appropriately and carefully selected. And I just want to emphasize that. That being said, opioids do bring with them significant potential for harm, particularly when used in a non-prescribed manner for a long period of time or in excessive doses. The most serious harms that can occur are fatal overdose and the current so-called epidemic, the opioid epidemic in the United States illustrates this very clearly, where opioid-related overdose deaths continue to climb year on year. Often, those overdose deaths are also associated with other kinds of substance misuse, other kinds of central nervous system depressants. There are other harms that can be incurred from inappropriate or hazardous opioid use, including sedation, including significant side effects, but most significantly outside of risk of mortality is really a risk of decreased quality of life and decreased function. Opioids are sedating. Opioids are central nervous system depressants. And at times, when they are used, again, in high doses or inappropriately, people can find it really hard to function well. And these are the kinds of issues that the task force tried to pay particular attention to in balancing between this maximizing potential for benefit, minimizing potential for harm. I know that there's also questions out there about risk of harm varying by dosage or by duration. And certainly opioid risk seems to be dose dependent or dose related. There are a variety of recommendations outside of our guidelines that suggest maximum dosing, and only careful consideration of individual patient circumstances when escalating above this dose. Duration of use is an interesting one that's hard to do justice to in this kind of a format, but I'll give it a shot. We know that risk of opioid-related harms goes up the more one uses them, and that's just common sense. The more frequently that one uses substances, the greater the risk of harm. That being said, appropriate long-term opioid use seems to be appropriate, particularly if it's working at an appropriate dose under appropriate medical supervision. It is when opioid dose escalates over time because of tolerance, things like that. It's when opioids are used in combination with other kinds of substances, benzodiazepines and alcohol principally, or when opioid use begins to be in a non-prescribed manner that we see real significant increases in risk of morbidity and mortality.
Okay.
So I'll go ahead and stop there.
That's great. Thanks. That's very clear. So Bart, we're back to you. So opioids are considered to be strong pain medicines. Like Kevin said, they can be very beneficial. So for example, in acute pain presentations, like after surgery or after a serious trauma, or in people with cancer pain, they can be very beneficial. But this position paper is clearly showing that their role can be limited in people with chronic non-cancer pain. So why do you think that is the case, that opioids can be effective for acute pain or in cancer pain and be necessary, but then be weak painkillers in people with chronic non-cancer pain? Is there any reason for that?
Yeah, thank you, Mary. A very interesting question. And indeed, I trained as an anesthesiologist, and indeed, opioids have been used already for centuries because of their strong pain relieving properties. And in acute settings, as you said, in surgery, after car accidents, trauma, injuries, these are the best painkillers you can get, and they will do their job without much harm. But it's a complete different situation once we look at chronic non-cancer pain. And over the last 2 decades, it became more and more obvious that these are not so powerful and that we cannot extrapolate all the properties in acute settings to long-term use in chronic non-cancer pain patients. And I see several reasons for this. First of all, chronic pain is not a prolonged form of acute pain. Other mechanisms come into place. Changes occur in nerves, in the central nervous system, spinal cord, and the brain. Chronic pain itself changes the function of many brain networks related not only to pain, but also to mood, your well-being, sleep, and so on and so forth. And this is extremely influenced by contextual and personal factors. So it becomes far more complex once you have these changes on chronic pain. And then the long-term use of opioids actually induces changes in the many neurobiological processes related to pain. And one example is tolerance, meaning that you need increasing doses to get the same effect on pain relief. And in some patients, you see that there is a very swift increase in the need of these drugs, whereas in others this goes much slower. So there is a huge inter-individual variability. And even more importantly, after a while, opioids themselves can change the pain system and even induce paradoxical reactions where patients become more sensitive to painful stimuli because of their intake, their use of opioids. And one example is lowering of pain thresholds, but also leading to generalized pain. And we call one of these examples is hyperalgesia. And so what mostly works extremely well in acute pain works less in chronic non-cancer pain, and works not at all in some specific chronic pain syndromes.
Okay, so it's very complicated. Thanks, Bart. So back to you, Kevin. So this paper overall could contribute, the two papers could contribute to a meaningful reduction in the unnecessary or irresponsible use of opioids for chronic non-cancer pain in Europe, which would be great, but it's very complicated. What health system changes do you think are needed? Or the wider team on this paper, what do they think is needed to achieve the goals of this paper?
It's a great, also a very good question, and I'll give a quick answer and then a longer one. What we would say is the task force, and we've been working on this for over a year. I think, what did we start? August 2019, Bart, something like that. I mean, this has really been a long and at least there is an intention to be careful about the process. So the first recommendation that I would make is consideration of the guidelines and adoption of them. And I think if that happened, then that would likely reduce unnecessary opioid prescribing and irresponsible. Because the guidelines are extensive, and really our task force membership was diverse with a range of individuals who were perhaps more pro-opioid, that's not quite the right term, but and folks who were a little bit more con-opioid or concerned. We had a range of expertise, a range of different disciplines. That being said, the rise of opioid prescription in the treatment of chronic pain came at the cost of reducing resources in other areas. And I think that was just a natural occurrence, that as opioids were prescribed more and more, particularly upstream in primary care, other kinds of resources were used less and less. So there's an opportunity here to take some of those resources that went into opioid prescribing and reinvest them into other areas, particularly in interdisciplinary care. We know that for people with the most complex, disabling, and distressing chronic pain, that intensive interdisciplinary pain programs are a gold standard. The drawback of those programs is that they are intensive, expensive, etc. However, these are the very individuals who seem most at risk from adverse opioid-related events. And I'm going a little bit beyond the data there, or making some comparisons, but that seems to be the true. So some reinvestment in intensive interdisciplinary care. In addition to that, there are a variety of non-opioid pharmacological interventions that don't carry with them the same risk profile, including things like nonsteroidal anti-inflammatories, paracetamol, etc. So they're antidepressants. There's a range of analgesics that seem to not carry the same kind of overdose risk. Those need to be considered, just as Bart said in answering the first question. One of the top take-home points of this is, before opioids are considered, consider non-opioids. There are a variety of appropriate non-pharmacological treatments as well, ranging from clinical psychology to physiotherapy to occupational therapy, all kinds of things, to self-help programs. There is a wealth. And again, just to circle back to my initial point, one of the real challenges here is, for good or ill, opioids were understood in some circles as a universal answer to the problem of chronic pain. And I'm not placing any blame here or pointing any fingers, just in some circles, that's how they were interpreted. That well-meaning clinicians thought opioids were the answer and started prescribing them as the answer. And they are not. They carry with them significant risk of morbidity and mortality. As Bart said, they just don't seem to work as well as we would like them to in chronic pain. And there is a history of efficacious treatments that preceded this explosion in opioid use that are worth reinvesting in.
Great.
Stop there.
So Bart, this leads on from a part of your answer to the first question, the three take-home messages, but what are the specific types of chronic non-cancer pain where opioids should be avoided? So they just shouldn't be prescribed as second-line care, third-line care. If you could just give us some examples of those conditions and why specifically should opioids be avoided in those populations?
Yeah, thank you. And before answering, I just want to echo what I already said before and was also echoed by Kevin. The general principle of our recommendation is that opioids are never the first step and never the first choice in the management of chronic non-cancer pain. So if you keep that in mind, that's really the most important one. But of course, we do acknowledge that there are situations where it can be helpful. So in our paper, we clearly state that opioids should not be used and not be considered for primary pain syndromes. And so we adapt a new ICD-11 classification where there is a new category, primary pain syndromes, and mostly for those who are knowledgeable with the clinical descriptors of pain like neuropathic and nociceptive. This would fit in those pain syndromes where you have mainly nociplastic pain mechanisms. And some examples are like primary headache, functional somatic disorders, chronic primary visceral pain, primary musculoskeletal pain. And importantly, this would include also a large group of what we call the specific low back pain patients, where we noticed that especially in the US, they were all put on strong opioids. And then, of course, also pain as a major manifestation of a mental disorder. These are really, should be red flags. Be careful, do not prescribe opioids. This would include then also chronic widespread pain type fibromyalgia. So these were then, so we really give guidance in which situations you better not use these drugs.
Okay, perfect. So Kevin, you referred a small bit to this in one of your other answers, but if an individual has the type of chronic non-cancer pain that Bart has just referred to, where opioids should not be prescribed, what type of treatment options should that type of population go to first? You mentioned some of them, but maybe what order, which ones are available?
I'll talk about which ones are available, and the sequencing is always a hard one that might be not possible for me to manage in a soundbite today in this interview. But I'll say this, just to echo that, there's a wealth of non-opioid alternatives, and the way that I think about this is as follows: that there is a pain management pathway, and that pathway is really about reducing pain. On that pain management pathway, there are non-pharmacological analgesics, there are interventions, injections, and those kinds of things, treatments, all the way up to surgeries or implantable devices. The important thing for me to communicate about that pain management pathway is that the primary treatment outcome being pursued is a meaningful reduction in pain. There's also again, what I think about as the pain rehabilitation pathway, the rehab path. Pain rehabilitation, the primary outcome is the resumption of meaningful functioning, even with ongoing pain. And let me note, these two paths aren't completely different. They just have somewhat different treatment goals. On the pain rehabilitation path, you may begin to recruit the services of physiotherapists or physical therapists, occupational therapists, clinical psychologists, interdisciplinary pain rehabilitation teams, and the like. And the purpose of those treatments, again, is the restoration of meaningful functioning, even with ongoing pain. And so whenever I am seeing someone at an assessment appointment, I think about these pathways. Is this someone who has not had the appropriate pain management interventions? If so, perhaps send them back to the physician or the medical team and say, consider these other things, consider these other approaches. On the other hand, if they've had a fair amount of those pain management interventions, to the extent that I don't think further pursuit of that is appropriate, it may be time to shift towards pain rehabilitation. And again, underneath each of those categories are a variety of treatment options that people who work in the area of pain will no doubt know of. Different disciplines, physiotherapy, OT, psychology, different analgesics, NSAIDs, acetaminophen, antidepressants, other kinds of analgesics of that sort, injections in certain carefully selected cases, and also perhaps interventions, surgeries, and implantable devices. I know that we're out of format here a little bit, but I'm going to, Bart, do you have anything to add to this? Because you have a wealth of expertise in this area as well.
No, Kevin, you clearly indicated the plethora of means to treat pain. And what I think a very important aspect is the education. So the patient education, if someone gets insight in the problem and the specificity of chronic pain, then it's easier to discuss also the options. And a very helpful framework for me in my contacts with patients is I always talk about my 3-pillar system, where you really need to address exercise and movement, or movement and exercise, and then you have the medical technical intervention, and maybe for an individual patient there is something in it which really works and is also workable for a long time on the long term. But then, of course, never forget also what I would summarize as train the brain concepts, where all the other issues are addressed, which is more in your field, Kevin, like psychological issues, but also social participation, all these issues. And although I know scientifically this is all interlinked with each other, all these 3 pillars, it's a nice concept to talk to your patient and to establish a framework where you can say, okay, if the medical technical interventions are in the middle and you can strengthen these outer pillars, you will be maybe able to function even without your painkillers, without destroying your home despite some chronic pain. So just giving a very pragmatic approach in my daily life, daily work with chronic pain patients.
Great.
Fantastic.
So Bart, this question is for you. If there's an individual out there and they're reading these recommendations, so it could be a physician, it could be a patient, and they realize that there is a situation where somebody is on opioids for a pain condition where opioids are not an option, are there any steps available for that person or that physician to help them either reduce a person's opioid use or help a person stop opioid use? This is in situations where opioids should not be prescribed for that population.
Okay, that's a very tricky question, Mary, because you have the 2 perspectives. You have the perspective of the prescriber, and some of the prescriber, and this has clearly been shown in the analysis of the North American opioid crisis, are non-critical in their prescribing, just giving refills even without reassessing the patient. So a first step would be to be, as a physician, to reflect on, is this still needed in my patient? Is there a benefit for my patient? So this reassessment is really key. And that means that we really need to get these guidelines out, that we need to inform our peers. And if you are in doubt as a healthcare provider, then there are specialists around who have more experience within the prescribing of opioids, in the long-term management of patients with opioids, but also in all the strategies to taper down and to stop. So if you're in doubt, seek help from your peers. From the perspective of a patient, that is also quite critical, because maybe some patients would not be keen to start a discussion of tapering down their opioids. And to give you one example, the 2 situations where we really need to intervene very diplomatically also with the prescribers are patients with a specific low back pain where there are no neuropathic pain components, and are fibromyalgia patients who were put by someone on opioids and are taking these drugs for many years. So if the patient is motivated, the same procedure, try to get into a respectful discussion with your prescriber. Doctor, are all my options taken into account? I never had more specific pain relieving techniques others than my painkillers. Is there something else to consider? And if you're not, if this is not your field of expertise, can you refer me to another colleague who can address this in a more multimodal and multi-professional way? I just want to make the remark that ideally, and we have, both Kevin and I have the luxury that we're able to work in these interdisciplinary environments. But in many areas in Europe, this is unthinkable. These structures are not available, but still there is some stratification and dosing possible in multidisciplinarity. Even a GP can ask the help of a psychologist or can get the help of a physiotherapist. So this, I want to acknowledge that it's not always that easy like we propose it, but that would be more the ideal world scenario.
Great. Thanks, Bart. So this runs into the next question I had, and it was more for Kevin. It was about this term multimodal, which is referred to in the position paper. And how do we bring multimodal together with multidisciplinary care if, like Bart said, if there's countries or parts of a country that don't have access to maybe multidisciplinary teams, how can a person still engage in multimodal care? Is that possible?
Yeah, there's a few points that I'd make here, and one just refers back to what Bart said, or his 3 pillars of pain care, which is kind of movement, physiology, if you will, or kind of the medical side, the biological side, and then functioning, psychology, emotional functioning. In addition to that, multimodal care, as I think about it, really refers to this sometimes overused term these days of the biopsychosocial model. And I don't mean overused in a bad way, I just mean overused in a way that we can say it and not really think about what we're saying. That the attraction of the biopsychosocial model back in the 70s was this acknowledgement that human behavior is a source of a complex interplay amongst a lot of different systems, including biology, physiology, psychology or emotional cognitive functioning, and then also social functioning. And I would think any person with disruptive, disabling, complex chronic pain is going to have needs in each of those 3 domains. They're going to need perhaps some kind of biologically oriented intervention to help them. They're going to need help with emotional and cognitive functioning, and they're going to need help with social functioning, particularly in the areas of independence or productivity. That's what we really mean by multimodal care. And there is no single intervention, no single analgesic, opioids or otherwise, that is enough to interact on all 3 of those different levels. The promise of opioids, and I'm sure people listening are like me, are old enough to remember the promise of opioids. The promise of opioids was that they were going to be the answer. And unfortunately, they just have not turned out to be the answer for chronic pain. They're inadequate to address this complex state of human being. The other thing that I'll mention is more indirect reference to the question you asked, which is, what about rural areas or areas that don't have access to interdisciplinary expertise? There are a few aspirational notes that I'd make, because as Bart said, we recognize there are problems here with access to care for individuals who live outside the population centers. The first is just for any treatment provider to keep in mind biopsychosocial model, Bart's 3 pillars, multimodal care, and to keep in mind what the indicators of successful treatment outcome are. The indicators of successful treatment outcome are likely in the area of productivity and independence. Likely. That is likely when patients will say treatment is working for me. The second issue here is if there are individual disciplines in one's local area that can be recruited to offer an integrated treatment of sorts, a physician, a physio, a psychologist, one can start to cobble together something that looks like an interdisciplinary team, at least in the sense of coordinated care. And I think that's what Bart was saying. That's possible. There are also a variety of self-help guides, a variety of online resources that are available to help supplement this. For me, one of the lessons of COVID and this current situation that we're in is that we can use technology to reach areas that we haven't before. And of course, this has been known, but even the format of the interview we are in right now, where we are 3 individuals in 3 separate countries having a real-time conversation about an important point, we can begin to recruit the expertise of clinical individuals into patient situations, I think. And the last point that I will make here is on a somewhat semantic point, but it seems important. Interdisciplinary care in the treatment of chronic pain for me is care from a variety of different disciplines who are all seeking the same treatment goal. Everybody is seeking restoration of meaningful functioning, as an example. multimodal care or multidisciplinary care, in my clinical experience, falls apart when the different disciplines are pursuing different objectives. When there are individuals pursuing pain reduction, when there are individuals pursuing increased exercise, those kind of mismatches between multidisciplinary care treatment provider outcomes are known by the patient, they're detected, they confuse the patient, and they can sometimes serve to disrupt care. So the old semantic point here is multidisciplinary care is a bunch of different clinicians who share some kind of space, but who each operate independently. Interdisciplinary care is a real integration where the entire team is singing from the same hymn sheet, is seeking the same treatment outcome. And I think in cases of chronic pain, to the extent that we can, coordinated interdisciplinary care with shared treatment goals is the best approach.
Okay.
I completely agree, Kevin, because with interdisciplinary care, it's less confusing also for the referring physician, for the patient itself, because
Yes.
we create one advice, we create one treatment plan and directions, whereas with the multidisciplinary, you indeed can get these contradictory and you advices, and you get separate advices. And so that's one of the reasons in the European Pain Federation we included a chapter on interdisciplinary care in our curricula. Just a side kick on interdisciplinary care.
Fantastic, great.
So Bart, this is a bit of a different question. It's when options may be considered. So what are the types of chronic non-cancer pain where opioids could be considered, maybe a second line option, third line option? Could you give some examples, and when might a person choose opioids?
In the preparation, the work in the task force, it was clear that for some indications, we do have some research that indicates that it can be helpful. One of the points is that for some of these clinical pain syndromes, we really lack the long-term data. But there are indications that low back pain where you clearly have predominant nociceptive neuropathic pain mechanisms, it might be useful to engage in a trial. And I always talk about an individual trial of this therapy with balancing benefit and harm, and then deciding if you continue or taper down and stop. But other examples are, for instance, knee osteoarthritis or hip osteoarthritis, osteoarthritis in general. There are studies clearly indicated that it can be helpful in selected patients in diabetic polyneuropathy, post-herpetic neuralgia, but by extension also a lot of these other secondary pain syndromes where clearly you can indicate a mechanism more on the nociceptive neuropathic mechanism than on the nociplastic mechanism.
Okay, thanks, Bart. So Kevin, you referred to resources and websites and the advantages of technology in your last answer. Are there any examples of resources or websites that an individual with chronic non-cancer pain could go to read more about these issues?
Yeah, there's so many, it's hard to, I guess there's so many, I should first apologize by saying I'm going to leave out some important ones, I'm sure. So I'm sorry to those of you who have developed fantastic resources that I'm going to forget. The overarching organizations here, including the European Pain Federation or EFIC, they have patient-facing resources, pain sufferer resources. So that is always a good place to start. And the advantage of going to one of the scientific communities is that the recommendations are going to have some science behind them. And that means that there is evidence that these things tend to work. In addition to that, there's the Pain Alliance Europe website, there's the Versus Arthritis website. All of these as kind of high-level resources, places to go resource shopping are a good idea. There are self-help books that are out there. Caudell's Managing Pain Before It Manages You, Dahl and Lundgren's Acceptance Commitment Therapy for Chronic Pain are just two examples. Bev Thorne's Cognitive Therapy for Chronic Pain as an example. In other words, there are evidence-based books that are out there that can help people guide themselves through this process. Finally, on some of the Australian groups particularly have been active in pain education, the group at NOI, Neuro-Orthopedic Institute, as well as at University of Adelaide. They produce videos that are pithy, they're smart, they're informed, they're evidence-based. And those are great places just to stop in and try and educate oneself on what we mean when we're talking about chronic pain. Two specific resources that I'll mention are a series of videos called, I have it up here, I'm just gonna make sure I get it right, called Brain Man, BRAINMAN. These videos are 5 minutes long. There's a great one called Understanding Pain in Less Than 5 Minutes. That is a fantastic resource. There is also a newly developed resource, again from the University of Adelaide folks, called Tell Me One Thing. And this is where experts get together and give one bit of information they really want people with pain to know. So that's where the title comes from. Just tell me one thing, tell me the most important thing. And I could go on and on about potential resources, but I'll take just a moment and say from the perspective of a clinician, where I would advise folks not to go, to be wary of going. There is a lot of information out there on the internet these days, and there is a lot of misinformation on what appropriate treatments are or are not. And I just want to encourage anyone with pain listening to this to exercise caution when they are getting advice from another person on the internet, that a lot of times these recommendations are simply not evidence-based. They have potential for harm. They can give rise to other kinds of inappropriate behavior. And so again, if you can go to the scientific societies to start with, the likelihood of appropriate information is increased than going to a social media platform or something like that and just getting advice.
Yeah, great, thanks, Kevin. So one more specific question. So this is for you, Bart. So as a physician, if you decide that opioids might be worth trying for a particular patient, what dose would be recommended and what kind of schedule would we be talking about? Would it be a fixed schedule that people have to take the opioids at certain times of the day? Or is it more flexible depending on how a person's pain is behaving that day, which can be very variable depending on the patient?
Yeah. Thank you. That's a very tricky question again, because opioids are one of the examples of a few drugs which are not dosed according to body weight, and where giving recommendations on dosing is extremely difficult. The general principle is you start low, you go slow. So you do a slow titration phase, meaning, and for those who do not have a clue what is a low dose, I would, we think in the range of MED, which means morphine daily equivalents. So calculating every opioid back to its morphine equivalent, that makes comparing drugs easier. A normal starting dose for a normal person would be around 20 to 30 MED. But be careful, because in frail patients, you need to start much lower. So very general principle, start low, go slow. If you do not have a signal in your reassessment that a benefit occurs between 50 and 90, then we really recommend to really carefully reassess, will you continue this, yes or no, or will you start already a taper process and stopping? You never stop suddenly opioids, you will taper. Or in other cases, you might it might be indicated to seek the advice from a pain specialist what to do with this patient, and to count on the expertise of your colleagues if you think if you think there is a need to go above these doses. Importantly, if we look at the recent international guidelines, including ours, that there is a dose range where there is a clear signal you shouldn't go above this without good reasons. And this moves between 80, 90, and 120, and some organizations even go below this dose range. And be careful, you really quickly are in these dose ranges if you just increase the doses. So no hard consensus, but that's a signal. This 90 between 100 should warn, and it should be a red flag, be careful. And then, of course, there is also not a general consensus on the term of long-term acting opioids and short-acting opioids. There are arguments in both directions, but in general, most clinicians will stick to the principle that you try to control the intake of opioids by time contingent intake. And I must say that from my perspective, this is not explicitly in the paper, I'm extremely cautious of providing patients with so-called PRN doses, which means providing them with prescriptions of fast-acting opioids. We really try to avoid this in our non-cancer population. And this is completely different from the cancer pain population.
Okay, that's very helpful guidelines. So there are all my questions. Thanks, Bart and Kevin. I was just wondering, have you any final comments on the position paper? Anything else you want to add before we finish?
I think much has been said already, and I just want to summarize it. What's clear from our papers is that opioids can be good, opioids can be bad, and taking the right choices and scrutinize and come to a responsible prescribing, and we can use like just every other drug in medicine. It all depends on the indication, the reassessment, and the decision, is this fruitful for the functioning of our patients on psychological, physical, and social functioning, including social participation. So I will stop here.
Fantastic. How about you, Kevin? Anything else to add?
Yeah, thanks, Mary. I'll say a few things. One, just going back to the guidelines, generally what we found as a task force was that the evidence base is limited and weak. Thus, we had to really rely a lot on good practice guidelines, on clinical expertise. And this is an issue for both clinicians and scientists to pay attention to. The evidence base for opioids in general, for chronic non-cancer pain, is limited and weak. Therefore, there is clearly a need for more work in this area. That being said, across this diverse group of task force members, there's generally good consensus for these agreements, again, both on appropriate and inappropriate use. And in many ways, these guidelines can be viewed as a consensus statements of clinical research experts, people who work day in and day out with those who have chronic pain, trying to give reasonable, sensible guidelines. That's my overall conclusion from this. I also, if I might, if it's not too indulgent, I just want to take a moment and say our primary task force leader here was Winfried Hauser. Without his work in this, these guidelines would not have been done. He was just so instrumental in this, and absolutely a pleasure to work with him, really drove this through. So he deserves special mention. The rest of the task force members, in addition, I won't name them by name because there were a lot of them, but I know for both Bart and myself, we're just so grateful for all their work. We had expert external reviewers who carefully went through everything, gave us really solid recommendations, disagreed with us when they thought we were out of line. And we also had a number of public commentators. I mean, so so speaking only for myself, this is the self-indulgent part. I think these guidelines are about as good as we could have done, given the limited evidence base that's out there. Last thing I want to say is Bart, as past president of EFIC, is really the one who drove this forward from the EFIC side. And so without that support, Bart, without you pushing this forward, these also wouldn't have happened. So that's it for me. Those are all the things I'll say. Thanks a lot, Mary.
That's a great.
Thank you, Kevin. Kudos to Winfried.
That was great. So thank you, Bart, Kevin, and yeah, we'll leave it there. And well done again on contributing to a really important paper on a really important topic. Thank you.
Thank you, Mary. Bye-bye.